Can you hear me all right? What Tamara's told us to do is to keep it short and leave plenty of time for questions, so that's what we'll do. I'm just going to speak for a couple minutes, and then Larry really will come on and talk in more detail about how he's applied mHealth technologies to support HIV prevention initiatives. I'm going to just talk very briefly about the platform a little bit that Larry will say more about, called IMOCA, that we built originally in Uganda but is now being used in Baltimore. Here's a little video that gives you a little introduction.
This is like the best thing. It's like my life is really so simple here. Yeah. I don't even have to be here anymore. I just give them a phone.
I could really travel with this, listen to all the lectures, be anywhere.
Yeah, exactly.
High utility. It will have a very high utility.
It's amazing.
We're really interested in using some new technologies that can empower people locally without having them leave their communities, give them training and capacity to deliver care and use the medicines and infrastructure that they have more effectively.
If we could find a way of being able to communicate to community workers on follow-up of a patient without them having to come to the facility, I think that would be a huge difference and make our work a lot easier.
This is heaven.
It is
fantastic.
Very exciting. I can see every student, every doctor actually having one.
The doctor can prescribe and say, you know what, this is what you should get, ABC. Yeah. And we are there. Wonderful. We're going to save a lot of lives.
So one of the things that I should have said in the beginning is that despite what you heard, I'm neither an mHealth expert nor an IT expert. In fact, my kids think it's a big joke because I can barely turn my own phone on and off without their assistance. But I've been interested in how to utilize technology and find smart people that know about IT to help us utilize technology to address health education and health research challenges. And so we built IMOCA, I think I've got a pointer here, in Uganda originally to do something like this, where you could have a health worker in a community linked by a device, either a pad or a smartphone or even a regular phone, that we could collect in real-time data back to a central server, perhaps based at Malago Hospital or here, where those data could be analyzed and we could identify practice data that would identify opportunities and need for training and education, whether it be for patients or providers. That those gaps would be identified by those data. We would create targeted training that would push out to the same device in the form of either consults, alerts, care algorithms, multimedia interactive training, a variety of ways of delivering and defining education. We use the same system to collect the impact evaluation on how well those interventions are impacting health outcomes that we're interested in. And it also links to cell phones that could be in the hands of patients as well. So it's an integrated system that allows all these devices to smartly talk to each other and to do it in a very secure HIPAA and steroids way. So that's it in a nutshell. I'm just going to introduce our interest in HIV prevention, and Larry's going to say a whole lot more about this from his perspective. But when we developed this, the first project we did with IMOCA was an HIV prevention project, and Larry will say more about that. And we thought that mobile technologies and a platform like IMOCA would provide a potential opportunity to deliver interventions at multiple places along this cascade. Delivering, and there are other examples of mHealth platforms already that are delivering HIV prevention education on smartphones, on regular phones, on other devices. What Larry's going to talk about is a program that was a voluntary counseling and testing program in rural Uganda that was an algorithm-driven program. I'll let him say more about that. So we think this, the system is also able to drive interventions for those that are HIV and uninfected through risk reduction, refer people to male circumcision, PrEP, and then for those that are infected to optimize each of the steps in their linkage to care, risk reduction, retention and care, define their eligibility for HART, and improve their adherence. So all of those steps we felt an mHealth platform would be ideal to integrating the steps. And I'm not going to say more and let Larry really elaborate on that in a minute. And that was really driven, as no surprise to people here, by recognition of this, as Larry calls it, the iceberg phenomenon, where there's a drop-off at each of these steps. And this is the care cascade, but you can make a similar picture for the prevention cascade, beginning with not even providing access to diagnosis for everyone that has HIV infection. And these are the data the data I first showed you were shown on this slide from the United States, but similar data from sub-Saharan Africa. And these are the percentages at each of these steps, showing you the drop-off at each stage for one of our partner organizations, Reach Out, in Kampala. So the problem is the same in the United States as it is here. And one of the nice things about delivering these kinds of interventions with mobile technologies like EMOCA is you can do it in multiple languages. This is our HIV prevention program that was developed for Al Vu and his team, I'm not sure if they're here, from Afghanistan, to screen commercial sex workers in Kabul. And I think they've hopefully are going to begin to collect data using this tool soon. Here's an example of what I think David mentioned is how you can put this is a visual analog scale that you would typically use in a clinic to measure adherence, and you can just touch the screen, or the patient or the provider can touch the screen. And if the system's set up so if it's less than 90%, it automatically drives the next question about, well, why are they not taking the medicine? Well, they're hungry. Well, let's automatically refer them to the nutrition program. So it's a simple example of how these algorithms can be smartly driven and drive referrals. Larry will say more about that in the prevention context in a minute. It also allows us to link the data to geolocations. This is actually from the Exact project in Baltimore. I'm not sure Greg is here. Is there anybody from the Exact study? Oh, there we are. Maybe you could pipe in later about your experience here with EMOCA for Exact and the new study. But it's going to allow some opportunities to collect data linked to geolocation, which will provide some interesting information and provide opportunities for new innovations around HIV prevention and adherence. Just in the last slide, I'll summarize where we are with EMOCA, and then Larry will take and talk more specifically about prevention. I think we've got 9 projects now. EMOCA is being used, I think, in 11 countries. There are 3 projects. This one was one that Larry will talk about. 3 projects that are related to HIV prevention. One in Uganda, the Afghanistan project, and then the Alive Exact study. We also have TB, dengue, oral cancer, and other studies as well that are all using EMOCA to optimize both the delivery of the intervention as well as the data collection and the research. So with that, I'm going to let Larry come up and say more about his work.
Thanks, Bob. So thanks, everybody, for coming. So I'm going to talk a little bit more generally about HIV prevention, about mHealth at first, and then hone down on a couple studies that we've done with EMOCA. And I also wanted to introduce this concept of combination implementation, because I really think you have to think about tools like mHealth in the broader context of HIV prevention. So, as probably everybody here knows, there have been many recent positive RCTs showing that these biomedical interventions like male circumcision, treatment as prevention, and pre-exposure prophylaxis have demonstrated efficacy. And this has been a very exciting time in the field. And it's led to this concept of combination HIV prevention, which is the use of multiple many biomedical interventions that, when used together, can perhaps drive HIV incidence down and perhaps eventually lead to control of the HIV epidemic. So things like male circumcision, treatment as prevention, PrEP, other proven interventions like prevention of mother-to-child transmission, combining them into a package and getting to decreased HIV incidence. However, one of the questions is, how exactly do you do this? You know, it's one thing to say we're going to do all these things. It's another thing to actually implement this in the field. So that led us, several folks, Ron Gray, and others, to really think about this concept and to do a review. And we kind of came up with this concept of combination implementation for HIV prevention. And we recently published this in Lancet ID. And the idea behind this is that combination implementation is the pragmatic and localized application of evidence-based implementation and operational strategies to realize both high sustained uptake and quality of HIV prevention interventions. So let me talk a little bit more about what that actually means. So in this review, we identified a number of implementation strategies for HIV prevention services. Those things like HIV testing counseling. Should you do that in the home setting? Should you do that at a mobile basis or use more classic facility-based HIV counseling and testing? We looked at different implementation strategies for treatment as prevention, like linkage and retention and care interventions, treatment support and adherence implementation interventions. What are ways in which you can better implement medical male circumcision, prevention of mother-child transmission, behavior change, and PrEP? And we also looked at a number of cross-cutting strategies for HIV prevention, such as task shifting, structural interventions, demand creation, and looked a bit at some of the issues facing key populations. So the overall idea of combination implementation is that in addition to combination prevention, you need a set of implementation strategies which will be unique and localized to your to each setting. Adding things in like maybe point-of-care CD4 testing, conditional cash transfers, maybe home-based HIV counseling and testing, various task-shifting initiatives, treatment support, and linkage to care. And when combined with the biomedical interventions, combining the what in HIV combination prevention with the how, you can eventually get decreased HIV incidence. So I think that's kind of the context in which I like to talk about mHealth, is this context of combination prevention and how mHealth can be a very powerful implementation tool to try to realize some of the promise here. So I'm going to start by kind of just describing how mHealth can be thought of as a tool and some of its different features. And I'm going to talk a little bit about the range of mHealth. So mHealth can have a lot of different features. You know, you can do things simply like making a voice call. That's kind of the first killer app of mHealth. But you can also obviously do things like text and do SMS, which stands for short message service, which is probably one of the most common interventions used for HIV prevention right now. But you'll have other things as well. You know, you can have a microphone, you can have a touch screen. Many phones have GPS. You can store things in the memory. You may have Wi-Fi connectivity. You can think of some more novel things potentially when you have things like accelerometers built into phones, Bluetooth, cameras. Some new phones have gyroscopes and even barometers. And these phones are all connected in one way or another with the cloud. So they're connected with servers, and you can access information or interact with them with personal computers. So these are a lot of kind of features and tools, and maybe you can start beginning to think in the larger context of HIV prevention where you may start be using certain features with certain interventions. The technology also has quite a range. You know, you have what some people call dumb phones, which are very simple phones where you can essentially just make calls and text. And I think anybody who's traveled in low and middle countries has really seen the dramatic rise of these types of phones over the past several years. Next up are what are kind of typically called feature phones, where you have a little bit more features. You have some, typically maybe a bigger screen, and typically you can access the internet. That's kind of one of the key distinguishing features. Then you kind of move to this spectrum of smartphones, things like you know, iPhones or Android-based phones, which is what we work a lot with. These are more complex, but you can have larger screens. You can have touch screen input, which is very important, especially when you're working with health workers. But you have trade-offs as well, like a shorter battery life. So there is quite a range in this technology too, and something to think about as you're thinking about using mHealth for HIV prevention. If anybody has any questions as I go through this, because I know we're moving a little quickly, feel free to stop me. So we can think then of what are the different ways we can apply some of these tools. And probably the most common thing, or one of the first things that was done, is really for data collection and basic surveillance, because you can really build relatively simple programs to do this. And you can send data very simply and inexpensively through things like SMS. But you can also see how you might start be using this for clinical decision support. And Bob showed some examples of that. Starting to guide health workers, maybe community health workers, clinical officers, et cetera, using algorithms built into phones as a clinical decision support device. Some people have started using these as kind of electronic medical records or extensions of electronic medical records. You can also see how it can be used for alerting, tracking. We show some examples of that. Of course, you still have very basic voice communication and text communication. You can start seeing, especially with the multimedia capabilities, opportunities for education. And at a more complex level, maybe seeing it as a portable medical device, where people have built features and applications where you can use it as an ultrasound for microscopy, for instance, looking at malaria smears, or as a portable EKG device. So you have a lot of different potential applications, and again, thinking about the larger sphere and where exactly in the HIV prevention spectrum you want to intervene, you can start thinking about how this technology may align. I think there's a lot of different things you need to consider if you're trying to bring mHealth to the field. Complexity, again, is an issue. Do you want to aim very basic, or do you want something very complex? And that'll probably depend upon the problem or the question you're trying to solve or answer. Availability. Do you want to make sure that all your technology is already available in country? Durability. Some of these conditions that we're working in may be quite strenuous. Dust, moisture. For instance, the phones we're using in Afghanistan are ones that needed to be very resilient and resistant to dust. So we got one that was water resistant and dust resistant. Portability. Some are much more portable than others. Cost is, of course, always a very important issue, as is battery life. And as you all know, power can be intermittent in some of these settings, and you may need to be very creative in terms of charging phones. And network compatibility is another huge issue. So it's an issue here in the U.S., right? You go to certain places and you don't get a signal. That's incredibly important as well when you're thinking about different HIV prevention interventions. And I'm not going to go over this in detail, but there is some complexity involved in thinking about not just the phone itself, but kind of the network and making decisions about that and the technology behind that, because that may kind of determine what you're able to do with the phones and with your different strategies. This is just a recent map of one provider in Uganda, and it shows in the darker colors their 3G capability. So that's huge, having 3G capability, because you can really transfer a lot of rich data very quickly. You can send PowerPoint slides, multimedia presentations, etc., and get essentially real-time feedback. In other places where you don't have 3G, where you may have things like 2G Edge or even very basic stuff where you can do text messaging, your interventions may be more limited in complexity. Now, there are a lot of things additionally to consider when choosing an mHealth application. Some issues include, of course, cost. And there's actually a lot of good open source and kind of free stuff out there. But of course, things that are even labeled as free or called open source still have costs associated with them. So that's always something to consider. You may still have to pay for the phones or for customization or for coverage. And I've just provided here some examples of what I think are some leaders in the field for looking at different types of interventions. Some of these are free, like Frontline SMS is a free application. We're doing very basic SMS-based interventions. There's some more complex things for like feature phone, like EpiSurveyor and ComCare. A lot of that's for surveillance. And then there's kind of moving to the next level where we focus a lot on, which is kind of taking advantage of smartphones. So just like you were seeing like 5-10 years ago, the introduction of basic phones, you're starting to see the same thing with smartphones in low and middle income countries. Android, for those of you who don't know, is kind of the operating system developed by Google. It's open source. And because of that, there have been a lot of different companies who are producing hardware, smartphones for it, particularly a lot of those based in China. And the prices for smartphones in a lot of these countries is dropping quite significantly. And I think we'll see, very similar to these basic phones, the rapid growth of smartphones in these settings. There are a lot of great resources out there already, so I won't go over all of them. For learning more about mHealth, here at Hopkins, we have the relatively new global mHealth initiative, and it's a great resource to see across the university what's going on. So that's a place I recommend if people haven't looked at that already. And there's some other resources there if folks want to learn kind of a bit more about the mHealth field. But since this is Hopkins, I think we should definitely ask, where's the evidence behind mHealth, and what's kind of our role in both assessing and producing some of this evidence. So this is focused mostly on low and middle income countries, but based upon our review, this is what we found in terms of some randomized controlled trials focusing on mHealth and HIV prevention. So the first one was actually just published quite recently in Kenya and looked at test messaging to improve attendance at postoperative male circumcision clinics. And just to summarize, they did see some modest but significant increased attendance at post-op clinics. The rest of these interventions are all focused on ART adherence. That's kind of where been the bulk of more rigorously designed trials have been focused using mHealth, really focused on ART adherence. For instance, Lester did a study in Kenya looking at text messaging with kind of provider support, and he found improved adherence in virologic outcomes. I'm going to talk a bit about this study we did in Rakai in a minute. Another study in Kenya showed that these text message reminders, again, increased adherence and decreased treatment interruptions. But as kind of a cautionary note, the last couple studies, another study done in Kenya, showed that an alarm device, it was kind of a multi-pronged study, that an alarm device, essentially kind of an mHealth type intervention, actually had no effect on ART adherence and had no changes in the virologic outcomes in this study. And another very recent study from Cameroon found that weekly text messaging had no effect on ART adherence in this randomized trial. So while kind of a couple of the initial studies really showed some positive effects, I think these other studies, and I think ours to a certain extent as well, say that we need to be a little bit cautious and need to think about the specific context in which are these being applied, and that we need continual evaluation of this intervention. And there have been different nuances. Some people send daily messages, some send weekly, some are more personalized, etc. So there's a lot of different things I think that still need to be figured out. But these studies are all relatively recent, and I think an evidence base is beginning to be created. But you can see this is somewhat East African-centric, and I'm going to show you where I think a lot of the huge gaps in the evidence are. Just as kind of a contrast, I just want to talk a little bit about some other innovative mHealth studies. If you look in the mHealth literature, there's a lot of stuff on kind of formative stuff, how many people have cell phones, are they willing to receive messages, etc. There have been those RCTs, but are more treatment focused. But there's also been some stuff which I think are a little more innovative. So for instance, Jessica Haber and David Bangford's group in Western Uganda have been doing more research focused, but doing some really crazy stuff with like real-time electronic adherence monitoring. And this is just a sample size of 10, but it's showing this device called the Wise Pill. And essentially, it's a wireless way to track people taking their medications. Each time they open this thing to take their medicine, it sends a little message, and then Jessica or David or whoever in the US can be tracking in real time are people opening up their little medication bottles and taking their medication. You can't really see it in detail, but that figure on the right is showing like daily summaries of when they're taking their medications. So they can then use that and correlate that with virologic outcomes and show what are patterns of non-adherence that correlate with virologic failure. So that's something which they're doing in Uganda, but could, of course, be done in a variety of different settings, including in the U.S., and could be applied to other things, maybe like PrEP, in which adherence is such a huge issue. There are also other devices that are being made, like little sensors attached to pills, so when you swallow them, you have a necklace and you can actually detect whether you are swallowing the medicine or not. So there's some really innovative stuff happening in that field, but that's really more research focused than kind of widely programmatically implementable. This other study caught my eye too, because it's thinking a little bit beyond the text message, which has been kind of such a predominant part of the evidence so far, which is kind of streaming videos to, I think this was a high-risk urban African-American cohort of young women, streaming them these risk reduction soap operas every week to try to see if that affected their choices. And this is an RCT. I don't think their patient-oriented outcomes have been reported yet. This is kind of describing their process. And then finally, to move this into another realm is to really start thinking about this a little more intellectually as well. You know, the technology is very attractive. People rush to get into the field. But I think there's a lot of room to think about this from a more intellectual academic perspective. This one paper, for instance, thinks about the conceptual framework about how you promote prevention among people living with HIV with SMS to start. So let's take a step back. How does this fit with our different behavior change theories, et cetera? And think about mHealth from that more academic, theoretical perspective. And we've tried to do some of this as well. So I think this may show kind of the direction of where some things are going in mHealth and where I think Hopkins certainly can contribute. But if you go into the field, besides, like I mentioned, surveillance, which is kind of an obvious use for mHealth, a lot of what happens is kind of these HIV communication programs. And I've just have a couple examples here. So this is a project in South Africa. I'm not exactly sure how to pronounce that if anybody wants to try. But this was a program, SMS-based, like many of these are, the Please Call Me campaign, where essentially this kind of tech incubator. So here you see some of the intersections in mHealth. You kind of need the tech side, right? You need people who have these skills in technology and software engineers to kind of be able to produce these things. You often also may need to collaborate with these IT companies like MTN in South Africa, which was the collaborator here, because these things can be expensive, and to send a lot of text messages, for instance, can be quite expensive for programs. And then you need people like us, implementers or researchers, to try to evaluate this and to bring things into the field. And that kind of interaction in the different cultures can be quite challenging to manage. But in this example, they just blasted the population with millions of text messages, and they've sent like 350 million text messages, and talking about South Africa's AIDS helpline. And then they report, this increased our helpline by 300%, and we attributed 1.2 million calls to this campaign. And if you look, though, for literature on this, which I tried to do, maybe it is out there, you probably aren't going to find it, but you'll find like a case study on their website or something like that. So this is kind of what's happening, I think, mostly. You have a lot of different SMS HIV prevention campaigns, sending out information. And you have a lot of these process results of differing levels of rigor. And I think this is definitely some place where we can contribute. As another example, Text to Change, actually based in Uganda, does a lot of SMS campaigns throughout Africa, kind of focused at the youth or in the workplace. I think they work with Japigo, for instance, on male circumcision in Uganda. They can do simple SMS interactive HIV quizzes and also send out adherence reminders as well. So I think this is a lot of what's happening with HIV prevention in the field, and a place where we need a lot more evidence. So I'm going to pause there and segue to some of the work and kind of how we've applied some of these tools and principles to some work here at Hopkins and through EMOCA. But does anybody have any questions on kind of some of that background and some of the tools and technology of mHealth before I proceed?
Larry,
yes.
In low and middle income countries, what proportion of people have dumb phones versus something beyond that?
Yeah, I think there have been different numbers, but I think it's something like less than 5% maybe have smartphones right now. But I think 5 years ago, maybe in the U.S., it was maybe something approaching that too. So I think that paradigm is supposed to shift. I mean, you can get like in Kampala an Android-based phone for like $100 right now, which is not too bad. And I think the prices will continue to be driven down by these mostly Chinese-based companies like Huawei and so forth, which can produce things quite cheaply and quite quickly, though their quality is debatable. So I'm going to start by talking about a study that we did of an mHealth intervention in rural Uganda and this mixed methods evaluation that we did in Rakai. So when this study was done, Rakai had a mobile HIV clinic strategy where it was community-based. The HIV clinic would travel out to these static sites once every 2 weeks. And as you can imagine, it's a challenge to get people proper follow-up care and get them to adhere to their medications when you're only on site once every 2 weeks or so. So we did a pragmatic cluster randomized trial primarily focused on the effect of using peers to support people on ART, but we built within that a sub-study where we gave some of the peers mobile phones and asked them to use them in a way to help support them versus not, as kind of an exploratory sub-study to see what benefit this mHealth intervention might have amongst peers. So 4 clusters got these mobile phone supports, and 6 clusters had the usual care without mobile phones. In Uganda, you actually can get pretty good coverage in a very rural setting. And for those who've traveled anywhere in low and middle countries, you'll know that a lot of the advertisements are all about cellular phones. This just shows these these peers being trained, these community health workers. And here they're learning how to use one of the mobile phones in the bottom left there. These folks, travel around on bikes in a very rural area, and just to give you an idea, you don't have electricity in a lot of these parts, but they're very creative solutions. So here's essentially a lead-acid battery that you hook up to the various devices, and you can charge your phones on it. So pretty much every remote village has some form of this where you can go and plug your phone in and get it charged for a relatively small sum of money. So how did they actually use the phones? So in this study, the peers were already collecting data on these home visit forms, and we simply had them transform this data into a text message. So we used all existing technology, and this was done about 5 or 6 years ago, so that they would transmit this data back to a central clinic immediately, with the idea that higher level providers could react to this information a little bit quicker, and that issues out in the field may be addressed a little bit quicker in people who had mobile phones. So just to summarize this one study we did, the process results showed that this was definitely quite feasible. Though it wasn't really powered quantitatively, we didn't really see any differences in terms of patient-oriented outcomes. We did do a complementary qualitative study which showed that really there was a lot of broad support amongst the patients, the clinic staff, and the PHWs, the peer health workers, who thought that it really improved patient care and logistics, though there were challenges identified, including phone access, network coverage, some privacy concerns, and maintaining the phones. But we eventually ultimately felt that this was overall a positive thing, and we kind of scaled up the use of mobile phones to all the different clusters. Another study we did in Western Uganda, which was recently published, was a collaboration with Connie Kellam's group and this NGO in Western Uganda called ICOBI. Now, ICOBI had done a lot of landmark stuff with home-based HIV counseling and testing, and they had kind of demonstrated that they could go home to home in this district and test literally hundreds of thousands of people for HIV. And Connie Kellam and their group were really interested in, let's use that as a platform for referring them to HIV prevention and care services. But you can imagine that can be quite difficult to do at scale consistently with high quality. So through a chance encounter in the lounge at Schiphol Airport, I met Connie Kellam and we're talking about some of the things we were doing, and she was saying, you know what, why don't we try using EMOCA in this setting? And that's exactly what we did. Trying to use technology and health to kind of standardize the process for delivering these interventions. So again, we have a pretty rural setting. They have these officers, these prevention officers they call them, who drive out or ride out to these villages and go home to home and test people for HIV. So what they called this was actually PreventionRx. They're going to give everybody a prevention prescription based upon your individual level risk factors for HIV. And they wanted to show through this study, can we implement household-based HIV testing with this HIV risk assessment protocol using mHealth eMocha? And can we then triage patients to HIV care and prevention services based upon their risk factors and HIV serostatus? So the way this works is essentially, you have these algorithms that you build. If the patient's HIV negative, not circumcised, male, high risk, maybe they need to be referred to male circumcision right away. And you just lead them through on a smartphone these different algorithms, and they tell the health officer what to tell the patient. And it also tracks. As you do this, it's being uploaded in real time to a server, so Connie Kellum and Jared can monitor this in Seattle while this is happening in the field. And it also remembers. So the next time you go to see that person again 3 months later, which is what they did, you can say, oh, you were supposed to get circumcised. Did you get circumcised or not? And then you can follow up in patients like that. Before they were carrying on these bikes, you can imagine, they test literally hundreds of thousands of people, reams of paper, and you can imagine logistically that's quite complicated. But here they really felt this simplified the process. And these are just descriptive process results, but over a few month period, they enrolled about 2,000 patients in this study. And shown here in these is just the cumulative probability of, at the top right there, of identifying HIV patients and referring them to care. And in this small pilot, we identified 152 patients and referred them to care. And you can see at those intervals, 3-month follow-ups, when you go back to the household, there was pretty good uptake in terms of people uptaking care. At the bottom there is a similar figure for male circumcision, and by the 3rd monthly follow-up visit, 62% of the folks who had been referred using this algorithm reported themselves as being circumcised. So I think that's a nice example of using mHealth as kind of a clinical decision support tool for HIV prevention. So I just want to mention this as well because some of this evidence is starting to make it into kind of guidelines and policy. These were some recent, and the first guidelines for focusing on kind of retention in care, engagement in care, and ART adherence, which was published in Annals last year. And one of the recommendations is that using reminder devices, mHealth, and use of communication technologies with an interactive component are recommended. And at the time, this was a 1B recommendation based on stuff done domestically, like reminders for ART adherence, as well as stuff done abroad. So some of this evidence, though I think it's still growing, and 1B may be a little strong, some of this is starting to make it into guidelines and policy. So just to finish up, I think mHealth is a very dynamic and it's a rapidly expanding technology. It's very interesting because things are constantly changing, but that also makes it quite difficult to study, especially when you think of like a classic R01, which has a 5-year timeline, and it takes 1 to 2 years to even get it through, to get funded, and that technology is moving so quickly. But that the range of technologies can range from very simple to quite complex. Similarly, HIV prevention is a very broad and complex field, and we think that this concept of combination implementation may be helpful in starting to move things to impacting at a population level. I think mHealth can be integrated into many different components in HIV prevention, from behavior change, ART adherence, et cetera. And that some of the early evidence shows some mHealth successes, and that the potential for mHealth for HIV prevention is significant, but there's still really a lot to do in terms of generating evidence and really moving forward with this technology to scale in a lot of these combination HIV prevention interventions. So I want to thank the many folks who've helped out with these different studies and work, and I'd like to thank you for coming today.
Questions for Larry?
This is the interactive part.
Yeah.
Yes, back there.
Larry, could you describe like the software development process and like what goes into actually making the forms for EMOCAR?
Yeah, so a lot of this is fortuitous, how this all started. I'm not sure, Bob, how did you actually meet our software developers? This is a funny story.
Well, so we were working on a project in Uganda to implement distance education programs for PEPFAR. And we were out in rural Rakai trying to figure out, well, you know, we can think about how to set up online learning for the universities, maybe in Entebbe or Kampala, but how are we going to get education and information to rural Rakai? And I had with me one of my colleagues who I had hired for this project, who was a Spanish IT guy. He looked up on the hill and he saw a cell tower, and he said, Bob, that's a French-made such and such tower. He said, that thing's got 4G capacity, they're just not using it. We could send live video, full, you know, high-speed, high-definition video all over Uganda with this kind of an infrastructure. They don't have any idea what they've got here. So I said, go investigate this further and find out if any, and we sat down afterwards and I drew out an idea for what I wanted an mHealth platform to do. I wanted it to be, and I sort of showed you that diagram where I wanted data to come from the field in real time, be able to be easily analyzed, push clinical algorithms or education strategically to the same device and evaluate it. So I said, go out and see if anybody's built this. And there's no reason to reinvent the wheel. He went out and he knew the IT business and came back and said, well, there are pieces of this puzzle, but not an integrated system. And I naively asked him, well, can you build it? And he, not naively, said, sure. And he pulled together, he said, we're going to have to do this in an open source platform. It's going to have to be on the Android devices for Africa, and also so that it's open source so that people could adapt it once we create the platform. People that have programmers can adapt it. And that was really the impetus behind this. And then he pulled a team of, we have open source programmers in Uganda, all over Europe, where else? India, I guess, that are, he's getting help from lots of people. He organizes it. He's based in Spain. He's our lead programmer. And then the way that the project has developed over time, we now have, I think, 11 projects. Each time we do a new project, the platform gets better and stronger, and we're able to leverage improvements in the functionality for each subsequent project. And so Larry and I and Jane and Miguel are the management team. We meet every week to kind of review the development status of the platform. I'm not sure if that answers.
Yeah. So technically the forms are XML forms, which is kind of a relatively basic form that, but they're programmed by this team, which has been assembled kind of across the world, you know, somewhat serendipitously at times. So it's kind of very interesting how the whole software world kind of interacts with us and how you pull in expertise from many different locations.
Now some of our partners, like Boston University, since the platform's open source, we gave them the code. So they uploaded the EMOCA platform, and they have their own programmers, and they're creating their own forms using our platform for projects in Zambia, and I think Mozambique, and who knows where else. And so that's one strategy, and there are other partners that need our help with the IT development for the forms. So it's a range of capacities depending on what people have in place.
For those of you who are standing, there are plenty of seats. Don't feel stand in the back.
Yes.
I actually have two questions. The first one is I was wondering if the findings from mHealth data, is it similar domestically as it is internationally? And the second one is, have there been any differences by ages? Because I would imagine that young adults or even teens would be more likely to uptake or maybe even use these technologies compared to adults?
Yeah, that's a great question. I don't know the answer to your second question, but that's a great thing to explore. There have been some domestically focused, again, mostly on ART adherence because that's kind of the big money. And that's kind of adherence reminders generally seem to work somewhat, though there also have been some concerns about quality of life and how do you actually do it best. And a lot of these have been very short-term studies too. So after 6 months, do people get tired of having a text message? So there's a lot of things that I think still need to be looked at.
I can remember when we first rolled out this program in Uganda, and we're talking to people here and there was a lot of skepticism from the gray-haired people that it would never work. You know, because we have uneducated low education levels in these villages, and the health workers in ICOBI snapped that stuff up so fast. I mean, if you talk to the programmers, they'll tell you they were the quickest learners of anybody they've ever worked with. So the Ugandan young people that were out there doing the data collection, they just snapped this stuff up. They were faster than the rest of us will ever be.
Ron?
Well, we've had some email exchange about your upcoming visit, and one of the things I asked was, what would you recommend for our combined prevention program, which is just starting up? So now I'm going to put you on this.
Yeah, no problem. So I think definitely we need an expanded peer-based support program where they're all linked with mobile phones to communicate. And I think we need to start taking advantage of this SMSing for circumcision reminders, clinic appointments, taking your ART, and then bringing essentially this this paradigm of what we did with Connie and UW to the household level, and expanding that, and maybe studying that in a trial-based format, which maybe we can discuss a bit more, to see whether we can actually see whether, besides just doing a descriptive process study, can we actually see some impact of doing something like this. So I think there are some things that can be done pragmatically, not ridiculously expensively, using largely existing technology.
So I wanted to ask Larry about this as a follow-up, because we talked about this idea for a project in India originally that we called the HOME study, HIV Care Optimized for Mobile Empowerment. And it really was leveraging and building on what they were doing in Uganda and thinking about specifically about HIV prevention and the different opportunities. I mean, Larry's already mentioned this, but it seems to me that one of the best hypotheses about the value of mHealth is that it really allows us to push the interventions to the home. So what do I mean by that? One is that accessing HIV, as we saw with the COVID, accessing HIV diagnosis in the home and facilitating the referrals in the home. One hypothesis is that's going to be more effective than waiting for people to come to a facility. The second is once they're linked to care, and engaging them and linking them to care from the home is easier than linking them to engaging them and retaining them in care from the clinic. So if you've got somebody going out every 2 weeks and saying, why didn't you go to the clinic? You missed your appointment. I mean, use mHealth to support that. The linkage to care, the retention to care is also potentially strengthened. And then finally, the adherence. I think for our study in India, my hypothesis is for that study is that when you assess adherence at a facility once a month, using whatever scale you want, whatever system you want, your estimates of adherence are going to be less accurate. Particularly, your assessment of what are the barriers to adherence are going to be less accurate. Take that assessment, or those assessments, to the home, somebody in the household asking you and looking around the house, are you taking your medicine? Why aren't you taking your medicine? The opportunity to identify the real barriers to adherence are going to be optimized in that setting, and using mHealth tools to push those interventions to the home, I think ultimately, if it can be done in a combination way, the way Larry's saying, if you can integrate the diagnosis, the linkage to care, the initiation of heart, the adherence to heart in a combination platform, mHealth is, I think, an ideal way to do it. I think the challenge is what Larry said. Let's do it in a significant, in a rigorous scientific way. I mean, I borrowed a phrase from others when I say the mHealth field is ready, fire, aim. There's stuff out there, but we're really not, except in a few examples you've heard from Larry, doing the right study design to demonstrate the kind of impacts that we need to.
Dick.
Getting to the slide that Bob ended with, the quote from Arthur Clarke, I think there are a lot of people who have expectations of magic from mHealth as opposed to finding that it is magical. And I think what you showed in terms of impact on adherence was mostly that there wasn't any because it's not magic. But conversely, what you showed is an extraordinary instrument, extraordinary tool, or a series of tools. And the study that you showed with Connie Kellum, was very impressive because you can have people biking around with a phone in their pocket, and they have the equivalent of the EPR system at Johns Hopkins, at their fingertips. So I think it's a really impressive tool. And one of the questions I have is about the the accuracy and quality of the data, and how, when everything is inputted in the field with a thumb on the phone screen and there are no forms to go back and check, how do you track data quality? How do you manage mistakes? What do you do about that?
Yeah, that's really tough. I mean, you can build in certain things like checks, ranges, etc. So you can try to eliminate some errors like that, and you can try to minimize some things by using appropriately sized fonts, etc. But you're right, there is no paper record. So one of the things is that because it's synced either in real time or daily, there, at least at this program, were daily quality assurance checks where they would look at the data and make sure it made sense and so forth. But you're never going to you sacrifice having the paper record. One could argue, even if you had a paper record, do we know if that data was accurate or not? Some of the other things that we kind of built in are you can GPS track, so you can tell whether the phone and the health worker was out in the field or out of these households too. All the households are GPS linked. So that can help you actually quality assure that actually somebody's not sitting under the tree filling out the forms, but going into the households filling out the forms. So there are trade-offs, I think, pros and cons in terms of cleanliness of data.
Yeah, I would just add, Miguel's talking to us about this, and he's got the system can actually prevent the health worker from even opening the form if they're not within a certain radius of the village or the household. So they're not even able to, unless they're actually going in the household, they won't even have access to the form. But the smartness of the system for data quality checks, if you're touching the screen and you hit an error that doesn't make sense with the rest of the data, the system will say, wait a minute, that doesn't make sense. I mean, we've got examples where, if somebody's circumcised last time and they're uncircumcised now, the system won't allow that. Now, with a paper-based system, you won't know that till you get the form back, you enter the data into the system. You build that, you can build that into the back end so that they're not allowed to answer, change the gender or change the circumcision status of the patient. And that can be in real time. That's one check. The other thing is security to think about. We design, text messages are not very secure ways to send information. So you have to be very careful about using regular phones for sending HIV prevention or HIV treatment information. So a lot of these reminders have to be designed to be pretty, pretty vague in the way that they're sending information. The smartphones are super safe, and so we can collect much more, specific information using the smart devices than we can with the regular phones. But I think security is another issue that has to be thought about when you're doing HIV, any kind of HIV work, of course.
Oliver?
Well, that was actually what I was going to ask about, was security in terms of having all that type of data. With how do you get it through IRB approval in terms of having the data access that the investigator wants in terms of all the GPS data, but it not be at risk, and especially in some of these places where some of the activities which may be illegal. So how is that dealt with?
Yeah, I mean, it's project to project, but some of the key things that we built in is all the data transfer is encrypted. The data on the server, of course, is encrypted. The smartphones are password protected, so it'd be similar like if you had data on a laptop, similar idea, you password protect it. So it's definitely an issue we're cognizant of. Like that study we're doing in Baltimore with Greg Kirk, we're not only collecting data on drug use, but we're collecting their day-to-day, moment-to-moment motion. So we're tracking where they are, and we can see where they're going and whether they're using drugs, craving drugs, etc. But I think that got through the IRB, but that's very important information because geolocation plus behavioral location together, you can target interventions. So as they're approaching, the shooting gallery, maybe pop them a message or send them a picture of their son or something like that.
Well, let me ask you, Oliver, what do you think is a more secure way to collect and store data? On a pile of paper on the back of a bicycle?
No.
On a password-protected, encrypted device? So,
I think it depends on who the threat's from. If it's from some nefarious government agency which is trying to gather at that type of data versus...
Well, they're not going to get it from the smart devices.
No, but they could hack into the server.
Well, they can do that with the paper data as well as
That's very true.
That's irrelevant to how they collect the data.
Then another question, what other types of device, I mean, in terms of lab-based testing, do you foresee that these smart devices may have access to in terms of potential for breathalyzers or even blood spot testing, or do you have any idea of like what's down the pipe?
Yeah, I mean, all of those things are actually either been thought of or done or prototype, because anything you can attach onto the phone you can do. I mean, like the ultrasound is a little device you plug into an iPhone and you can have a portable ultrasound.
Yeah,
so
any
pretty much
device
anything.
you connect by Bluetooth or USB, you can collect the data. So it's really, whatever you put on the end of that, the data will come through.
Ted?
Hey, this might be a little premature to ask, but this is a follow-up to the aside that you made about the sort of 6-month period of certain folks feeling passive, and I was wondering if some of the studies, or maybe ones that are underway, are showing time effects, whether it's either exhaustion or decay in terms of the impact on adherence, just because we're thinking in terms of the need for lifelong adherence. Or does that seem to be a fact, or are there certain strategies that are more sustainable than others to use this?
Yeah, I haven't seen too much on that, so I think that is a huge question. Now that we're moving to more of a chronic care model for HIV treatment, is how do you maintain adherence? So that's, I think, an important question that we need to look at.
You know, it's a great question. So I'm sure it's one they're thinking about with the exact study as well, as you look at people not just doing adherence, but retention and care over the long term. And, you know, as you begin to think about, on the one hand, pushing these support systems out to the community instead of having them be facility-based, you might hypothesize that would be an advantage over the long term. On the other hand, it might disconnect them from the clinics and their counselors in a way that might actually accelerate the process. So we don't know. I think those are the kinds of things that need to be studied.
Yeah, a lot of our paradigms are really using mHealth to empower a healthcare worker. So it's really the provider support that's probably the most important thing, just augmented with mHealth technologies. For instance, what we're doing in Baltimore, again with Greg Kerr's group, in this R21, is we're actually having peers collect information from their other peers, and this peer navigator has this kind of augmented level of information about their peers to provide support and so forth. And some of the other studies have done the same things. It's not necessarily the reminder, it's just a conduit to providing more kind of quick social or support.
So why don't we move into the next phase, which is, do we have some refreshments? Yes, I believe we do. And let's continue this informally. We have the room for the next hour, so please sign in the back. Thanks for coming. We have to know who was here. So thank you.